Perfect. Hey, it's good to see you. It doesn't seem like we have much opportunity to get together in the same room and chat. Usually it's via telehealth or video conferencing.
Yeah, no, it's great to be in person, hanging out.
Yeah. So let's talk a little bit about kind of what got us here. Providing diagnostic evaluations via telehealth. And so kind of what got you involved into psychology? Give us a little bit about your story.
Oh, sure. Yeah, so Dr. Jaye Turrietta, everybody calls me Jaxcy, and I started getting interested in psychology in high school, actually, and that's when I also learned about autism. I was really fascinated by it and also just felt such compassion for the group of people that were affected by it. And so then I actually volunteered with the New Mexico Autism Society. Mm-hmm. Loved it. Yeah, it was really fun to work with them. And then after that, I went on to college at the University of Kentucky. Go Cats. And that was a really fun experience. I got to learn even more about autism and psychology as a whole before eventually going to Rutgers, which I was fortunate enough to attend. That also has a fantastic autism program.
Absolutely does.
Yeah, big focus in the whole state as well. So highly diverse presentations and just really great experience. And so every experience I've had just fueled it more, kind of across the board. And then I came back to New Mexico, did my internship here, and have been here kind of ever since.
So are you originally from New Mexico?
Yes, born and raised in Albuquerque. Yeah, and yep.
I think in my brain I had you in Oklahoma. That you started in Oklahoma.
Family's from there.
Oh,
yes,
family's from
yes.
there. Oh, okay.
So it's also Boomer Sooner.
Yeah, no, exactly. Yeah.
Spread around. They didn't used to be in the SEC, but
yeah.
Now they are.
Yeah. Well, and kind of Boomer Sooner. So that's where I went to school. Did my
Boomer
undergrad
Sooner.
there at Oklahoma. Came back to New Mexico, originally from New Mexico, kind of all around. And then decided, I wanted to go into psych. And went out to San Diego, did my psych program out there. What's funny is initially I was going to do learning disabilities, had no intention of specializing in neurodevelopmental disabilities. And at that time, I've been in the field for a while, obviously got some gray hairs. And at that time, there wasn't even really a neurodevelopmental disability movement or anything. And so started graduate school, showed up first day, and professor said, well, you got to find someone else, I'm retiring.
Oh. Really?
For his own, so it's like I'm in a lab. I'm not in a lab.
Yeah.
And so then the only other person specializing in child services or child research and experience was in autism, and went, man, I'm like, all right, let's do it. Nice. The only other thing I knew before that was in my psychopath class at OU. The professor said, oh yeah, autism, that's something that you should be aware of. It's 1 in 500. There's more people that want to work with individuals with autism than individuals with autism.
Oh my gosh, what a shift.
Yeah, so what a massive shift, right? When I first started, the early diagnosis was like age 6 or 7.
Wow.
And I was lucky enough through some of the NIH grants that we did, we're doing some fMRI, PET scans, and MRI scans. So high-end kind of cost per subject. So we were able to bring in Kathy Lord at that time, who was kind of piloting the PLADOS and eventually moved over to the ADOS, which is the gold standard for helping diagnose autism, and kind of got trained up by her to do diagnosis, which was awesome. And just kind of kept on moving along, ended up coming back to New Mexico and worked at the University of New Mexico Department of Pediatrics. And we traveled the state doing diagnostic evaluations, which was awesome.
Yeah.
And being able to give back to the community. And New Mexico is a the geographic area creates massive access problems. And so at that point, traveling around was really the only way a lot of families could get access to specialty care. Mm-hmm. And now you actually see telehealth kind of coming in. And one of the grants that we had at UNM, Center for Development and Disability, was a HRSA grant I think it was in like 2006, to start using telehealth, which was dial-up
Oh my gosh.
via phone.
Oh,
And
I complain about connection
yeah,
now.
no, yeah. And so, yeah, so in 2006, we got got a HRSA grant to expand telehealth services for early intervention, autism, consultation to rural areas because of the geographic difficulties. So that was really my first introduction. It was challenging. It was very challenging. As compared to now, where we are in terms of being able to utilize telehealth. And so that's kind of how I got involved in telehealth, was very early, and then, recently really picked up. What about you?
Yeah, I think it's really interesting that you bring up sort of the rural need for this. I'm sure we'll talk more about this later, but it was interesting, being in New Jersey and people talking about the Echo model. And I was like, oh, I know about that. I'm from there. And they were totally shocked.
Yeah.
And people still, because that's generally considered a higher resource area, more condensed area, obviously. And just a different way of thinking when there's distance, let alone everything else that's happening throughout the state. So
Is it okay if I interrupt real quick? So the ECHO model was developed by Dr. Sanjeev Arora here at the University of New Mexico to serve individuals with Hep C. And the model really is bringing multidisciplinary providers in rural areas to train them up on the complexities of treating Hep C. And as you know, the ECHO model has also been kind of then morphed into other disciplines, other services to really train up providers in a variety of areas.
yeah, thanks for explaining that.
Yeah.
Perfect. So that was kind of an intro to telehealth in graduate school. Did a few things, but not too much until actually when I came back for my internship here. COVID disrupted my internship year. So,
wow.
yeah, so it was the second half of my internship year, and they suddenly said we cannot do these evaluations in person, which was scary for several reasons, including how are we going to do them at all? We have to do them. I mean, who else? First of all, for the community, the UNM, as you work there, UNM CDD does a high amount of these, and especially at the time, if we weren't doing them, who was going to be doing them?
Yeah.
And I did see the wait lists go really high. We attempted to adapt, but there really weren't a lot of options. I remember us doing like ADIRs, autism diagnostic interviews over the phone with families, and just trying to piece everything together, somewhat doing it with masks, but until it just totally shut down completely.
Yeah, COVID changed everything.
Yes, it really did.
It was a paradigm shift.
Yeah, just how we're going to look at things, how we're going to gather information even, and then what do we do with that information? How are we going to help these families? Because, even if they could travel or we could travel to them, we still can't do it in person.
Yep.
So how are we going to do this? So that was it was definitely like my first real experience, like trying to do that without any other options.
It's funny you mentioned that, because that was really the shift for me, or for our team also. It was around COVID, and it is a paradigm shift. It's slightly different in that that's kind of how you make, that's how you made a living, was through those evals. And well, now I don't have a means to make a living. I better figure this out. And so really spending a lot of time on the research, problem solving it, and kind of coming up with the foundation for a lot of what we do now around the idea of kind of a contextual behavioral assessment, where we're really looking at the behaviors of a condition in the context that they happen, which is a huge shift for what we do with evals, any kind of eval. Usually families come into a clinic, they meet you, and you're kind of extrapolating, oh, hey, yeah, I hear you're having these difficulties, but tell me how that affects you at home. With telehealth, you see the exact behaviors right there, and you don't have to, kind of extrapolate how severe is it. You just see it. It really is terrific. And that was a shift for me in the clinical service.
Yeah. Do you remember any of these cases or things that stood out to you as you were doing that
Oh
and
my
seeing it
gosh.
happen?
Yeah. So even thinking about the first telehealth eval I did, I mean, sweating bullets and is this going to work? And the child was already a med frag. So he was already, bringing him into the office was going to be challenging to begin with, but now it's COVID.
Right.
And so it's like, well, if we're going to try it, this is the best case to try it on. And, so it was modifying, some of the, it's like, is this going to work? Is this going to work? Started the history. The history was easy, not a big deal. And as I'm talking with mom, just asked her to turn the video around. It was a little, I think 4-year-old, maybe 3 years, a little, almost 4. And everything mom was talking about, I'm just like, yep, there it is. There it is. Yep. See it. All right. Got it. Yep. See it. And then it's like, oh, well, it's time for the structured play. Well, I've already seen all this.
Sure.
Do I really need to have a structured? And so I went ahead and did it, kind of had parents go through some of the structured plays so that I could see the behaviors again. But it was really an aha moment for me that, wow, the reason we have these structured play interactions in the office for in-person is because the kiddos we're evaluating have no toys that they need. You're trying to elicit these behaviors, these low occurring behaviors, so that way you can score and say, oh yes, we saw these specific symptoms. Right. To then, in symptoms, I should rephrase that. We saw these specific behaviors that we can classify as symptoms of a condition and diagnose. And I'm kind of like, wow, I already saw this in the exact context. The great thing is that parent was so relieved. She was afraid that the mom was afraid that we weren't going to be able to make the diagnosis because her child behaves so differently when in the community because of all the restrictions they had to put on the child due to the medical conditions. And so she didn't think he was going to get a diagnosis. And I'm kind of like, yeah, did you see this? Did you see? I saw that. I saw, yeah. She's like, that happens all the time. But when we're in the community, it never happens. It's like, perfect. And that was truly this really works. And we didn't quite go full tilt for telehealth at that point, but we really started making that shift.
Yeah, that's amazing because it's true. It's well designed to do the best that you can, but it is contrived, right? When you're in a clinic, the kid has never seen you. It's probably never really been in a clinic space, at all. Yep. And so now we're just trying to create the scenario so that we can see it versus how amazing is it when we're seeing how things actually are.
Yeah.
Yeah.
Well, and so I specialize I've specialized in really littles kind of through 18. But my specialty is really littles. Now you serve adults. Can you remember kind of that first experience around telehealth and doing an adult eval and how that differed or what your thoughts were and kind of the experience overall?
Yes. My first one, I remember also being a little nervous, although I kind of comforted myself in thinking, well, with an adult, there's less play. So I don't have to come up with toys or other things. And hopefully their behavior will need like less redirecting by others. So we'll see. But I was kind of like, anything could happen.
A little nervous. You're like, nah, I got this. I got mad skills. I got this. You're really I'm sure.
I'm going to come in here,
I'm sweating bullets. You're like, nah, I got this.
At least present that way. It's probably not helpful for the person because I will say almost everybody I interact with, whether it's via telehealth or in person, I ask how they're doing and there's almost always some anxiety around it. So very normal experience, but also probably not helpful if they're like, I'm really anxious. And I'm like, me too.
Yeah.
So, although like in the situation I was, and is still going in there with the confidence of, okay, I'm going to do my best to figure out what's going on here. And recognizing, so with my first patient was a female who had struggled for a long time And at the point where she saw me, she was actually living separately from her family, although she was young. She was about 19, but things had gotten so bad at home and they just didn't know why. And so she was aggressing towards herself, towards other people. She didn't know what was going on. And there's just a lot of people throwing spaghetti at the wall kind of thing. And there were a lot of people that weren't going to see her because of her, kind of history of outbursts, and her family wasn't sure about even transporting her places. So she was happy that we could do this version of telehealth, and so was her family, so that it could actually happen at all. But still, hard to say then, okay, well, what is this though? Because one person with autism, right? So I went in not entirely sure, but hopeful that I could get the pieces while still being able to create a good connection with her, because that's very important in the eval, because even that part's a little contrived. With adults, there needs to be a little more checking in of like, how are we interacting with each other? So I remember going through it and feeling like I got all the information I needed without too much distress, really, which was nice for her and for me, to just kind of feel like we could do this. And she, at the end, felt like it was such a good explanation, right, for what was going on, and her family too, because now they could get help. Without that, it's really just waiting until you're forced into some other situation. Cops are called, which had happened, unfortunately, to her. Or she gets institutionalized, until we can find other ways to help her. And if nobody's going to do this evaluation, she can't get these services. So I remember that. I mean, like, this is important. And so I have to get good at this, essentially.
One of the things you made me think about was another client that I had done an evaluation. And initially I was very skeptical to take the client, simply because there was neurosensory deficits. So they had some functional impairment in terms of our functional visual impairment. And I was kind of like, no, telehealth's not a good match. And my wife said, Brian, if you aren't going to do it, this family's in rural New Mexico. Who else is going to do it? You're so smart.
Yeah.
All right. And I'm so thankful that I did. It was just a great interaction with the family. The family was so appreciative. They had been looking for a psychologist, and they're on the border of. They were on the border of New Mexico and in Arizona, in a very, very rural part of New Mexico. The eval was actually done on phone and cellular. As opposed to even the internet. And so, but they were so appreciative. They were looking for someone in Phoenix to do the eval, and no one would take the eval in Phoenix, even as in person. And the family felt like, I got every bit of information, got it, that they weren't sure about the diagnosis initially, after I was able to kind of point some differences out between what we would expect for individuals with functional visual impairment and some of those behaviors, because you can get a lot of repetitive behaviors that look very similar. But with his repetitive behaviors, they were very typical of an autism diagnosis. And so they were so appreciative. And again, it was a family that had difficulty even traveling. Wow. And so they would have had to travel about 4 hours to get to Albuquerque, and it would have been longer to get to Phoenix.
Yeah, and just the stress of that, right? How do we plan this? How do we make this happen?
Yeah. Well, one of the other things that we see is initially I thought it was really great for rural families in rural areas, the hard to access services. Families in metropolitan areas, and I've done evals in a bunch in New Mexico, but in Denver, Phoenix, Miami, Cleveland, and those are big cities. And so getting to major hospitals where the multidisciplinary teams are is a huge effort for them. And they've appreciated they've appreciated telehealth, because then they don't have to schlep across the city to get to the university to do the eval with all the challenges. And they can just, from the comforts of their own home. And so the what I thought was a great bridge for geographical barriers, telehealth's a great bridge just for convenience, regardless of location. because there's families that have difficulty with transportation, right? Needing to take Medicab, which is a Medicaid kind of taxi, or needing to take the bus. And so there can be families in metropolitan areas that have great limitations to access, as well as families that the child's behaviors can be pretty extreme, and traveling can, even in metropolitan areas, limit access to community, just getting out in the community due to elopement or something, that it really increases their parents' feeling of safety to be able to do the eval. So it really is amazing to see how the technology bridges the gap regardless of location, if it's rural or in metropolitan areas.
Yeah, it hits so many areas, right? And I know you deal with this potentially a little less with the littles, but it also has me thinking about, when I see adults, all the masking, just the stressors. And when you're going into a major hospital.
What's masking?
Masking is an attempt to fit in into a society or group or setting that is not designed for you. So that can happen to avoid ridicule or any other sort of negative consequence. It's pretty common for people that are neurodiverse to develop different strategies to navigate these settings, but they occur for pretty much everyone. Any group that is, experiencing some sort of minority setting. So it can be women, it can be people dealing with depression, it can be people of color, people with all sorts of abilities, things like that. Just it's an effort to hide whatever aspect of yourself could be negatively perceived by another person.
And then a lot of times it does take a lot of energy to mask or camouflage kind of the symptoms, meaning you're kind of coming out of it's like this little butterfly coming out of coming out of the cocoon, blossoming, but then just exhausted and kind of going home and crashing almost sometimes.
Yes.
Due to the energy, just to kind of shift perceptions.
Yes, yeah, because it's a lot. It takes a ton of energy to present yourself as something that you are not, and to be monitoring and mimicking constantly is exhausting.
So you're saying that you're seeing at times through telehealth some of the impairment because the masking's not going on?
Yeah, I would say masking can definitely still happen over telehealth, but there's less. So going into, if you have to go into a major hospital setting, you are interacting with a lot of people in a setting that you maybe have not had positive experiences, or you've really scripted, and that can in and of itself just be exhausting going through that process before you even would meet with the team. But then you also have to potentially continue to mask because you're meeting with doctors, and it's hard to set that down. I think it's much harder to do that in a hospital setting than it is in your own home. For instance, I have someone who I saw in both of those settings, and we were actively working on masking before he sought an evaluation. So it's like unmask in these settings because it was so hard on him, and yet we couldn't get him help from his doctors because they couldn't see it. So I give this analogy quite frequently where I say, if you go into the doctor's office and you say, I think I've broken my right arm, but I want you to figure that out by looking at my functioning left arm, it's going to be really hard. And so we have to kind of work on how we can do this together so that they can see it without you necessarily putting yourself at risk of being mistreated or misunderstood. So yes, exactly. And being at home where hopefully they can experience what it's like to be authentically themselves, just like you were saying with that kid, you're like, oh, this is what they're really like at home. We can hopefully see more of that with adults as well, and they'll be less distressed is the goal.
A couple of months ago, I saw a 16-year-old out of Florida, and he was, he had been diagnosed with autism when he was 4. He had had a full neuropsych 4 years earlier at age 12, diagnosed with level 2 autism at age 12. and I was seeing him again at 16, and I go into the eval thinking, okay, well, we're just going to renew the diagnosis. That way he can continue to get treatment, not a big deal. And the individual that presented is vastly different than the individual that is described in his full neuropsych.
Interesting.
And so immediately I'm like, okay, all right. We'll call him Keith. Keith is clearly masking. How am I going to get at this? And through the interview via telehealth, Keith's talking to me, and he and I hit it off like right away because he's wearing a hat of a marathon that I ran.
Oh, nice.
Happened to run. And so we're vibing on that. And he turns to me and goes, what other marathons have you run, Brian? And I'm like, wait, what?
Yeah.
And why that's important is because a lot of times individuals on the spectrum or with some neurodivergence really aren't interested in what you do, right? Or what you do. Gosh, I can't even talk. Kind of what your perspective is, or what you're doing, and
or how to get that from you,
or how to get that from you. It was just
hard,
natural. And so, oh well, here's what I ran. And he goes, oh, I've always wanted to run that one too. Tell me about it. I'm kind of, wow, that's really okay. And so then he and I are talking, and his stepdad shows up, and I had asked his stepdad some background history, and stepdad starts answering a question totally unrelated. Okay. And Keith's like, hey, Dad, he's talking about this over here. Yeah. I'm like, all right, this guy's, Keith is much more attentive and aware of the whole conversation than his dad is. He corrected his dad 3 times to bring him back. And so then just kind of, so now I'm presented with, and this Keith wanted to go on to military school. Cool. And was a straight A student now. And he talked about how he went through all the therapies and they really helped, but it wasn't until he went to Montessori school, they shifted his school from traditional school to a Montessori school, that he started learning how he learns. And then he really identified an OT that he vibed with and was just, he called it, he gave me a cheat code to social skills. Nice. So now I understand it. And he gave me the cheat codes. I get it. And as we're talking and, everything that he's describing, I'm like, he doesn't meet any of the criteria. Yes, he has some special interests, right? Yes, he likes space. Yes, he likes airplanes, but he wasn't stuck on them. Yeah. And so now I'm kind of the first time ever in my career. Really? Let's call it 25 years. 25 years of doing evals. Wow. For a 16-year-old, I had never removed a diagnosis.
How did they respond to that?
Mom was like, yeah, I think that's right. Yeah, I didn't think he had autism anymore. He's better than his twin brother at social skills. Do you mind seeing his twin brother? Because I think his twin brother might not have been diagnosed. But yet Keith doesn't have autism. And this is and then there's like, well, what does this mean for military school? I'm like, I don't know.
Yes. Gotta ask them.
But I mean, he was like the captain of his cross country team. He was the captain of his ROT. I think it thriving. It was absolutely thriving. Yeah. And so being able to see that, and again, the whole idea of masking, because that really makes it hard to diagnose, is that masking piece for adults, or even for some of our school age kiddos that are impacted, and that we can get at that through telehealth really is pretty cool. And that was one of the things I was pretty skeptical about initially.
Yeah, well, and I would say, that's so amazing. And one of the things it reminds me of is what we're doing now in terms of our ability to really engage. Like, I've compared it with, right? Like, oh my gosh, yes. Because we don't have to be, looking away and writing stuff down, or looking through specific prompts or things like that. We can actually see, am I getting the right toy out? Am I getting, the right items and setting them up correctly and revealing that, it's really a process which can be important, but because we're not contriving it, and because we actually have all this cool new tech support, I can really engage. I'm not missing these conversations they're having with others. I'm not missing the eye contact or the lack thereof, or like you said, sometimes there's low incidence behaviors, like the repetitive behaviors or interests. Like, I can really follow that and look at that and ask about that, because I wasn't looking down at my paper making a note. So it's really helpful.
There was I'm going to tell a story and I'll get to it, so just bear with me. There was a study that showed if you show up to your primary care provider's office and give them a lollipop, you will get a more accurate diagnosis than if you just kind of show up.
What? Do you remember?
I'll find the study. I'll get it to you. We'll link it in the notes.
That's fascinating.
And so it's like, wow, if you're just kind of engaging, right?
Yeah.
And so then and that study stuck with me. Not that I've ever taken a lollipop to my, but I need to.
I'm considering it now.
Yeah, exactly. And so, but when you have the tech stack, and I don't have to worry about taking notes now, that kind of first time I went from just telehealth to telehealth plus a tech stack to allow me just to be engaged, I left that, I finished the eval, and I was like, wow, that was awesome. Yeah. All right, I'm ready for another. Whereas usually, I mean, doing the work is an energy or is an emotional load, no matter what. And afterwards, I was like, wow, I feel a little more refreshed. It's like someone gave me a lollipop, and I feel like I'm better. I really am better at my job now with being able to engage, being able to be responsive, attentive, right? So now I might just make a quick note about a behavior I observed versus having to write what the parent's saying, the behavior, and think about what I'm going to do next, and how does this relate, and where are we going, and how am I going to talk about the diagnosis, where do I want to put this in the feedback? Wow, I can just be present.
Yes.
Imagine that.
Yes. How nice is that?
Yeah. And then my charming personality comes.
Yes. Like they get the whole you. Yes,
you get the whole package.
Yeah.
Unfortunately for them.
Love it. No. I'm sure families love this.
Yeah. Now it is just as a psychologist that has done this for years and years and years and years, it's a shift. Yeah. And it's a shift in a very good way where your provider is truly engaged. It's virtual, but I'm more engaged virtually than I am in person because I have so much going on in person. And I have an in-person, most of my evals are telehealth anymore. I happen to do going to be doing an in-person tomorrow, and the family has been waiting for an in-person. They didn't want to do a telehealth. They've been waiting 8 months.
Oh my gosh.
For me to be able to have an opening via in-person. And part of that's because I live in Denver and kind of commute in, and when I commute in, it's
but that's not unusual, right?
Yeah, no, exactly. So 8 months is pretty reasonable.
Actually,
and we've referred them out, and they said no, they want a eval from us because they've heard that we're the best. So okay, yeah, great. Hey, there's other people, and no, we want to do it. And so, and I reviewed the history, and I'm like, man, this kid has clearly got autism, and we just waited 8 months, unfortunately. And, for us, I think our next eval's within a couple of weeks, if not within a week, the same week.
Yeah.
And just the change of that. And so I'm happy to be doing the eval. I'm glad we got him in. I wish I could have convinced the family to start with telehealth, then we'll follow up with an in-person. Because that's typically what we do, right? Is hey, we'll start with telehealth. If there's something that we aren't sure about, then it'll be a follow-up. Like, hey, or let's get some more data. But if it's like, no, we truly aren't sure, then it's, hey, let's get you into, here's the diagnosis at this point. It might include autism, it might not. It might be a rule out. And a rule out's typically, hey, there's some things here, but I can't quite verify all criteria. I want you to see an in-person. And we'll get them into an in-person. Many times for our littles, if it's there, we'll say, hey, we're going to give a provisional diagnosis. A provisional diagnosis is a working diagnosis that's viewed as, hey, we need to see the client back within a year to say, is it autism, is it not autism? But in that year, you get access to services.
Yeah.
Night and day difference.
Yes. Huge. And
it's huge difference. And I think it does add some comfort to families to know that, hey, there's a plan here. It's not just telehealth, one and done. No, that's not it at all. It really is the providers want to be present, want to be there supporting you through this. And just like any eval, in person or not, the psychologist may be, yep, I'm 100% correct, which happens a lot via telehealth. There's other times they're like, yeah, I'm not really sure. Same thing in person. There have been many in-person evals that I'm like, I'm not sure. I've done follow-ups from telehealths where our psychologists have said, oh, we need it in person. I do the in-person, and I'm like, yep, I see the exact same things that you do. Clearly, let's call it autism. Or, yeah, I'm not sure. I see exactly what you do, and I think a provisional is the best way to go. I'm not sure. Recent study out of, I think it was out of Tennessee, out of Vanderbilt, that showed that telehealth is 90% as accurate and reliable and stable as an in-person evaluation for autism.
I mean, can't say I'm surprised, but
I'm
would
not
also
surprised
love
at
to
all.
see that study too.
Yeah, and yeah, we'll post it in the notes. And I'm almost convinced that the difference was probably 50-50 in accuracy.
Sure. Like it wasn't a clear,
It
obvious,
wasn't. It wasn't that
you know,
telehealth
missing-
was inaccurate.
Just even if you were comparing two different
Yeah.
evals,
Yeah.
it would be like that.
So the reliability and the stability of a telehealth evaluation is basically the exact same as an in-person.
Well, right, because that's higher. Typically, we'd be looking for 80% agreement research reliability.
Yep.
So that's higher than even that standard.
Yep.
So
That's terrific.
great. Yeah,
Yeah.
it is.
It really does, you know, and then having those backup opportunities or options to ensure when there isn't,
Yeah.
you know, there isn't definitive conclusion around the diagnosis, but we're able to at least give direction.
Yes.
Hey, here are the next steps. Here are things that we would look at. You know, the 16-year-old that I was talking about earlier had recommended. He had dyscalculia and dysgraphia, and I was like, you know, I'm going to keep those diagnoses, even though I didn't do any testing. We'll keep them, and here are the interventions that I want you to go and do for those. And around dyscalculia, it's a fluency thing around math. And so, hey, I want you to go to Fit Learning and do some fluency for, you know, and that's really going to help. They also do big 6+6 kind of fine motor strengthening and to help with the writing. And so it's huge, right? To be able to say, and that's a very unique kind of intervention that we're able to recommend. Despite not having, you know, kind of they were presenting for an autism eval. No, it isn't this, but here are the other things you want to do to continue to you know, promote the development and skill acquisition.
Yeah, I think direction is more valuable than a label most of the time.
I agree.
So even just being able to start there, there are even conversations, bringing it back to masking, where I have with patients of, you know, I think that it's possible that influenced testing today. Regardless, you're reporting that you're masking a lot. We know that impacts well-being negatively in the long term, regardless of how you're doing it or why you're doing it. So I would recommend working on that.
Yep.
You know, finding somebody that you trust to help you figure out when it's helpful to use a strategy and when in the long term it's actually more harmful, and what we can do also as clinicians to help you with that, so that you're not stuck in this place where you have to keep kind of pretending that you're somebody you're not, and then not knowing where to go with that. Right, giving you any direction of like, this is something you could work on. This is something we can help with, whether or not it's autism, whether or not we're 100% positive. Getting access to just some direction of, we see your concerns in the context that you are living, and this is what we recommend, I think is huge.
Absolutely. Regardless of what that diagnosis is.
Yes.
To be able to give that broad perspective on next steps is
Yeah,
awesome.
that's definitely our goal.
Yeah. So, all right. So I'm going to change topics on you a little bit. I've been privileged to be able to work with you for the past 4 years.
Yeah, can you believe it?
That's crazy
Yeah.
that you've tolerated me that long. And you know, I feel like when we started with the Rural Healthcare Delivery Fund grant to expand diagnosis
Yes,
across New
amazing.
Mexico,
So grateful to be part of that.
that there was still, you know, coming on board. Had you done a lot of telehealth evals before then?
No, not a lot. I think I'd been doing telehealth evals for 6 months, like really focusing on only that. The rest of the time it had been mostly in person with maybe a few telehealth evals, and then probably 6 months where I like really just dove into it. Yeah, before you all invited us on. So that was really exciting and nerve-wracking. But again, the way you guys set it up, I've learned so much, and I want it to continue.
It's so terrific to be able to expand access. And I think one of the pieces we really tried to do is help our providers that were joining us to expand that network was to have a conversation, because the modality is a different modality, right? We're trained that, we're going to give an IQ. We got to do all these testings to be able to confirm the diagnosis. And there's a major shift here where we don't necessarily, it's a philosophical understanding that the diagnosis is behavioral diagnosis. And as long as we see the behaviors, we can diagnose autism. Was that a major shift for you as we started talking about it? And yes, we can do some IQ stuff via telehealth for sure to help qualify for developmental or for Medicaid waiver services if need be. But was that thinking about the diagnosis without the extensive hours of standardized testing a huge shift for you? And were you nervous about that, or?
Yeah, I would say it was somewhat of a shift. So I have a background in applied behavior analysis, which is,
Oh, so you're like, this is easy.
Yeah,
I got that.
like, no, I would not say that. I still wouldn't say that. But I think that it was, in terms of gathering information, I recognize that there's a lot of different ways to do it, and that we are constantly looking for behavior in context. So that was really my focus, especially with treatment. Like we, of course, knowing the diagnosis can be helpful because it can provide direction, but really, a lot of my training is in how do we approach things in a profile, like in what are their concerns, what are the issues, what are their strengths, how are we going to put this together for each individual? So I think I had approached it in a lot of different ways, although, yes, with my standard training, I do think adaptive and IQ are still really important measures, and emotional scales, and there's all sorts of measures and information that we need to gather, but how we gather it, I was excited to hear about how you all were doing this, because I had also seen it. For instance, I had done evaluations on people that weren't using very many words, and I felt like that was us forcing people who have different abilities into our abilities, and like forcing that sort of observation and measurement, and saying like, well, this is the standard, and so you must do it this way, which is really distressing. Like the number of behaviors that you get when you're trying to force somebody who can't even speak to go to a certain level on a test. It's just unfair to them and upsetting. And so being able to get that information in these other contexts, and maybe potentially, with different measures, and bring it all together, is just super helpful, I think, for everyone. So while it was still new when we did this, I felt supported, and I was excited that there was something else that we could do to get that.
And we do have a lot of psychologists applying to work with us, because it really does fit a work and lifestyle that they're wanting. And the questions always come up, well, how do you do this via telehealth? Some have a little bit of experience, some have behavior analytic backgrounds, others have very neuropsych backgrounds. And so it really is talking about, I think you said it beautifully, that we're looking at behaviors in the context that they occur, and we're looking for behavioral symptoms. And it just makes, to me, if we could move all the initial evals over, particularly for autism, to telehealth, it would drastically change access. We would start treatment earlier, and kind of kick the definitive diagnosis down the road for those that we're unsure of, but they get access to treatment right away, and then an in-person or a follow-up. Because again, once you get treatment, now you have you do the diagnosis, you get treatment, you then see how that treatment impacted that individual skill set. And so we've had a kid, I've done an eval on a 2.5-year-old who looked pretty autistic, said, okay, I want to see you back in a year. Saw him back in a year after intensive ABA, and it's kind of like, well, yeah, I think you still meet criteria. Let's keep the diagnosis, but wow, this kiddo's, your son has changed drastically. And they haven't come back for the 3rd-year follow, or for the 3-year follow-up. But that alone, I'm talking about seeing one family 3 times in 3 years.
Wow. Yeah, and you can see these changes.
Yeah, you see the changes, but
it's amazing.
Also the traditional model, major universities have
right.
24 to 36-month wait lists.
Yeah, it'll take that long to just be seen once.
To just be seen once.
And that's
I'm
crucial
seeing them 3
time.
times.
Yes, and you see the progress, and they again can have direction, as to what to do in that period instead of just, wait until somebody will see you.
Yeah, so not only is it a paradigm change for how we think about delivering services, it's a paradigm change for families' access and consistent access, continuity of care that have, to a specialist that I'm then able to consult to a primary care physician around the medical needs, right? The little 3-year-old that has sleep difficulties, calling the pediatrician. Yeah, this isn't a typical sleep difficulty. I think, we need to work up sleep apnea, but I'm also a little concerned about some seizure activity. We've got to get that worked up. And it really does increase access to the not only diagnosis but to specialized services, because a lot of pediatricians, a lot of primary care physicians don't understand the medical complexity around autism, and to be able to give feedback in a little bit of subtle direction makes a world of a difference. Some of the kiddos we see in treatment will have a lot of restrictive, repetitive behavior, rule-bound behavior that will, you take away Thomas the Tank. Oh, Thomas the Tank is a bad one. You turn off Cocomelon, the iPad. You try to take the iPad away, meltdown. You change a routine, meltdown. That so much so it's hard for the family to even function because they're walking on eggshells. They're worried about changing a routine for that child. And being able to consult with the family and help them understand how that can be a repetitive, or how it's definitely a repetitive behavior, and it's impacting their feeding, right? They have the brand loyalty. They'll only eat, McDonald's chicken nuggets or McDonald's French fries. I mean, I love me a McDonald's French fries. I haven't had one, but I love them, and I get why they restrict to that. And so families will put fries in the McDonald's container that way, and the brand loyalty. It's this rule-bound behavior that then even the intensive behavioral providers are struggling with it because it's triggering behaviors. You can then consult, we can then consult with the primary care provider to help bring some medical treatments in to reduce that intensity, to then allow that individual to not be so stuck, not to be so repetitive, routine, rule-bound, and be able to engage in learning activities. Changes their trajectory.
Right. Yes. And all these different systems can be connected.
Yep.
So.
No, absolutely. So
I don't know how to wrap up. We can talk about
so
this.
So it has been terrific having an opportunity to sit down and talk. We got to do this more in person, not just via telehealth. But so thanks for inviting me and having me.
Yeah. Thanks for being here, Ryan. It's been great.
Take care. All right. We're only 45 minutes, 47 minutes.